morning. This is a 58-year-old gentleman with type 2 diabetes who is presenting with few months symptoms of diarrhea daytime and nighttime mixed with mucus. Initially it was thought that it was a side effect of the drugs for diabetes, but then after changing them, the symptoms did not change. So today's procedure will be having a look to see if there is any signs of chronic inflammatory disease in the bowel, as well as if there is any signs of, for example, microscopic colitis that could be the reason for something like that. So we are using PCF H290 scope from Olympus, and the patient was prepped with a combination of bisacodyl and picolax. Initially, what we start doing here, right when we're in the rectum, we try to aspirate all the air that we have there. So this PCF that we use here is not compatible with the scope guide, unfortunately, but the concepts remain the same when doing colonoscopy, regardless whether we have the scope guide or not. So after removing the air that is in the rectum, we start with our water immersion technique. In the PCF H290, H290L, we do not have the near focus mode either that we sometimes like to use in the initial part of the procedure, but that is more like a luxury to have in most units. So right now, as you can see, that I've passed the rectum and the rectosigmoid junction, and I'm in the sigmoid colon, approaching the proximal sigmoid and heading into the descending colon. I have about 25 centimeters in the patient, and I have good one-to-one contact with the scope, indicating that there is no loop building as we proceed. Now, as you can see here, that the descending colon is wide open, which is really tempting to just rush through it, but this is the idea here. We need to shorten the colon as much as possible. So we do this water exchange technique where we fill up the colon with water while we aspirate the air that is there, and that is just to reduce the sharpness of the angle at the splenic flexure, so that when we are there, we do not form a loop that might cause discomfort for the patient. The patient has received only 10 milligrams of Buscopan, so he's almost unsedated for the procedure. So as you can see here, as I continue approaching the scope with the splenic flexure, the scope is moving freely, and this is the nice thing about water immersion, is that we can actually oil up, you may say, the wall of the colon. And this is a really nice way of thinking about it, compared to CO2 that would just overinflate the colon and would end up moving to the right side of the colon. Now right now I am in the at the splenic flexure, I feel, and this would be the optimal time to change the position of the patient. So as we see now that we have moved patient to the to the back, right away we moved some of the fluid away that was piling up in the picture, and then we can continue with our examination. One thing that I've been noticing so far as I'm continuing with this procedure is that the wall of the colon does not seem to be totally healthy. I feel that the wall is slightly atrophic. Like I can see like the ridges and the fissures in the wall of the colon, but it's something that we'll be paying more attention to as the withdrawal process. Usually we're seeing the bubbles is see like the moon the crescent shape of the appendix is right there. First sign that you're looking for, that your first landmark that you should document. Usually, tip of the crescent is pointing towards the entrance of the terminal ileum, which happens usually to be at 10 o'clock when you have a straight scope, and this is where you see it right there on the top left side of the screen. And we're using a distal attachment, which is a very nice way to move the folds away so that you can maneuver yourself into the terminal ileum without having to force yourself in, without having to traumatize the valve, and use a slight insufflation as well as some water jet in order to lurk the scope inside the terminal ileum. So what I'm doing here is I'm using counterclockwise torque with the big wheel up, and I'm just using the small wheel very, very occasionally here to basically get that right or left movement in order to reduce the strain that I put on my own wrist. Otherwise, some people have smaller hands who may not reach the small wheel easily. They can rely also on the wrist for that, but that can be detrimental in the long run in terms of ergonomics. So now that we're in the terminal ileum, it looks pretty nice and healthy. Don't see anything out of the ordinary. You see the villi, they're pretty normal here. One nice test to do here is to flood the area with water and see what happens with the villi, and they should rise up and start dancing and moving around, and this is a good indication that the intestine is healthy. So I don't see anything out of the ordinary here. There were no obstructive symptoms and nothing like that, so there's not much of an indication to proceed into the small intestine farther than the initial 10 centimeters or so. I think we did slightly more than that in this case, and then we start the withdrawal process. And as we do that, it's very important that we have a system here as well. So we're turning the patient's position. We're using generousness of water jet. So on the way back now, and as you can see here, we have exposed this area much more nicely, and you can see like we're almost starting to lose the effect of the Buscopan. So this is usually a good time to actually add another 10 milligram Buscopan. So one thing that I'm seeing here is, like as I said in the beginning, it's like there's like kind of a cracking of the mucosa that I'm seeing in this part of the colon. Colon is well prepped. There are some areas that could have used a little bit more water ingestion by the patient in order to clean them up, but we will not be complaining about that. I mean, this is as good as you can get it most of the time in this part of the world, in my experience. So one thing that would be good to do in this place, in this area, is to try to go back a little bit and locate your ileocecal valve and choose one of the folds, and then do retroflexion in the right colon in order to see behind the folds. And usually it's best to choose a fold that is on the right hand side of the screen, and basically pass the scope alongside it. And as you go there, you go with the big wheel up, all the way up, and then the small wheel also up, all the way up, and with torque, either clockwise or counterclockwise, depending on the situation, and you should be able to get a nice retroflective view of the cecum, as you can see here. This is something that sometimes people are quite anxious about doing it because of being afraid to cause any perforation. The concern is valid, but with good good technique, it should be a very safe thing to do. It is not more dangerous than doing retroflexion in the rectum, which is a standard part of any colonoscopy. And what this allows you to do is to see behind these folds that would be really, really difficult to see behind otherwise. And you should not underestimate this, since but 65% of post-colonoscopy colorectal cancers are located in the right colon. It is important that we look in this part properly and we investigate it very thoroughly. My personal practice is that I spend twice as long in the right colon compared to the rest of the colon in a standard procedure. And I have noticed that it has increased my adenoma detection rate and sessile serrated lesion detection rate significantly. Now, given this cracking that I'm seeing here in the mucosa, I'm going to be taking some biopsies, and we'll be sending them for histopathology. What the mucosa looks like is not indicating that there is an inflammatory bowel disease, such as like ulcerative colitis or Crohn's disease here. What I could imagine this might be is some sort of microscopic colitis, lymphocytic or collagenous type. And you can see that it's not everywhere, like this diffuse kind of slight atrophy. This is just a small damage caused by the scope during retroflexion, but it's not a problem at all. So when you take biopsies, if we're now suspecting that we might have microscopic colitis, it doesn't really matter where you take the biopsies from, but if you take them proximal to the sigmoid, you increase the yield and the diagnostic probability. So there's two ways of doing this. You can take biopsies from different stations and put them in separate jars, or you can collect biopsies from different parts of the colon and put them in the same jar. From a therapeutic point of view, it doesn't matter if you find microscopic colitis somewhere, you're going to be treating it open, systemically anyway. It's not like so from that point of view, I do not see the reason to put this biopsies in separate jars unless I find something specific that may necessitate that. Now that I'm done withdrawing the scope, we are putting the patient back on their back. We can investigate this part of the colon and the left lateral, or you can do it in the back as well, depending on the visibility. And I see I have perfect visibility here. I don't have a lot of fluid pooling, so I can see the whole lumen without any issues. Next biopsy, please. Same jar, yes, thank you. And as you can see here, like as we come closer to the mucosa, you can see like there's a little bit of cracking and there's in the mucosa. You see this, Rania? And vascular pattern is pretty okay, I would say. It's the surface pattern that looks a little bit distorted, but again, this is not the endoscopic picture of any severe colitis. Open, close, open, close. We always need to think about the green endoscopy and to reduce our carbon footprint and the plastics being used. So the idea that we can collect the biopsies in one jar, unless we find something specific that would need to go in a different jar, would be a good idea. So now we are at the hepatic flexure. And you can always see this bend with this large corner that usually we get around on the way up. And photo documentation is a very key aspect of the procedures that we do. So it's highly recommended that to have this system in your head as you withdraw the scope, so that you do not take pictures randomly, but rather have a system. So and then the cecum and the terminal ileum and the ileocecal valve, retroflexion, and then you take one in the ascending colon, at the transverse colon, and descending colon. You take one at the flexures, then you take in the sigmoid, and you take in the rectum in the forward view, and the retroflexion view. And that is a very good way of managing, of having like adequate photo documentation. Whenever you have something that is out of the ordinary, that looks abnormal, you should first of all try to wash it properly. Maybe it's just some remnants of stool, or maybe it's just some mucus, but that's the first thing you do. And then you look at it with white light, and then you switch to MBI and have a look. And if there is something there, you should be able to see it by using this combination of techniques. And you cannot ask the patient to be even cleaner than that. So I think this is very, very well prepped colon. So we're going to take the next biopsies, and we're putting them all in the same jar. And it's very interesting when you use different endoscopes in one day, and you compare like the quality of the image that you see. I mean, this is the H290 compared to the HQ290 open, and close. The quality of the image is just so different. Open, close. So now we are we're reaching the splenic flexure, as you can see here. Then you get this other bend. Now when you are here, there's two ways again of doing this. Either the patient can be switched on the right hand side, which would open up the right colon nicely, or they can continue to be on the back. It all depends on how easy it is to visualize the mucosa. Quite often you need to change the position systematically, but if you're getting a perfect view of the whole image, there's no need to do that. There's no absolute need to do that during withdrawal, other than a few specific situations. Because I'm getting a very nice view of the whole colon, I do not see a reason for the patient to change his position in the bed. And make sure that every time I withdraw from one fold of the colon, I have to make sure that I have inspected every part of the fold, above it and below it and to the sides. and ensure that I'm not missing any important piece of information that might be subtle. You see here, for example, right now, as you can see, like the vascular tree, this well organized vascular tree of the sigmoid colon. That's a good indication that we're almost in the sigmoid. We have about 25 centimeters inside the patient. The scope has been straight and the patient has tolerated the exam very well so far. Open, close, open, close. It's very important not to get too excited and withdraw the scope too quickly unless they have seen everything. Sometimes you get like this area with the mucus cap, or you may think that there is maybe a flat polyp hiding under, so it's important to wash that mucus cap away and look. SSLs in the left colon are not that common. They're usually hyperplastic, so it's more likely to be of clinical interest when found in the right colon. As you are back in the distal sigmoid and close to the rectum, the best thing to do for the patient is to turn them back in left lateral position, because that would allow you to do your retroflexion with the least amount of resistance. So before doing the retroflexion, it's important to withdraw all the way back to the anal verge, and then identify it, and then proceed to the first rectal fold. Empty it from some of the water that we had infused in the beginning, and then you try to push the scope forward slightly, up, forward and backwards, as you shake it while going up with the big wheel at the same time with the small wheel, and you shake the scope a little bit, and that way you will actually get the perfect view of the rectum without having to push too much or overinflate or anything like that, which might be very painful and causes a lot of discomfort for the patient. And very important that you inspect the rectum in retroflexion from both sides. And once this is done, you go back to forward view. Try to empty the colon from any extra gas that you might have accumulated there, and you extubate under direct visualization. And this was the end of the procedure. Thank you very much for paying attention.